Hi, I am Professor Akshay Pradhan from Department of Cardiology, King George Medical University, Lucknow. Today we will discuss something about dyslipidemia or lipid disorders and stroke, or what you call fallish in Hindi. The burden of stroke in our country is growing as the burden of the risk factors like diabetes, hypertension, obesity, old age is growing, and the incidence of stroke continues to be high. Stroke is primarily of two major forms: ischemic stroke, where you get a blood clot in your brain, and hemorrhagic stroke, where you get bleeding in your brain. If you look at the population-based studies, major risk factors of stroke are diabetes, hypertension, and dyslipidemia. Now, generally, the cardiology community has been focused, or the overall vascular medicine community has been focusing on dyslipidemia management for atherosclerotic cardiovascular disease. But if you look at the primary prevention data, the reduction of coronary events with dyslipidemia management and the reduction of stroke with dyslipidemia management are equivalent. That means if you look at the cholesterol trialist treatment analysis of more than 1.5 lakh patients, if you use statins to reduce overall vascular events, then both stroke and non-fatal myocardial infarctions are equivalently reduced. And there is a huge body of primary prevention data from statin trials that if you lower your LDL, then you get equivalent reduction of both coronary events and stroke. And we have dedicated trials in stroke population, like the Sparkle trial and the Treat to Target Stroke trial, encompassing almost 6,000 patients, showing that if you lower your LDL with high dose statins or with or without ezetimibe, then you get good reduction in not only stroke events but also cardiovascular events, coronary events, even revascularization. So in both for primary prevention or for secondary prevention, your LDL needs to be lower, with obviously the commonest drug is being statins. And we at Lipid Association of India indicate that for secondary prevention we have to be aggressive, and our goals should be less than 50 at least for stroke patients. And in patients of stroke with additional risk factors like diabetes or other vascular diseases or high risk features, then the goal should be less than 30. And sometimes if you continue to have recurrent stroke events, your goal should be less than 15 even, according to the recent statements. And for management, I think you always start with high intensity statin, then gradually you add up with ezetimibe and bempedoic acid. And if this triple combo does not work, you can go for injectable therapies like PCSK9 inhibitors or maybe inclisiran for that matter. With respect to the fear that if your cholesterol is very, very low, then the risk of intracerebral hemorrhage or bleeding is there. That data was seen in some epidemiological studies and the initial Sparkle trial, but much water has flown under the bridge. We have now large body of data from the IMPROVE IT trial with ezetimibe and the PCSK9 trials with alirocumab and evolocumab, that is the 4-year odyssey, where even LDL levels as low as 25 are safe and there is no increase in hemorrhagic risk. So stroke, like coronary artery disease, needs an aggressive lipid lowering approach. And for primary prevention, I think you look at the simple ASCVD risk algorithm by LAI, where you just look at the risk factors and put your patient whether moderate, high, very high risk. Or for secondary prevention, all stroke patients are at very high risk. And if you have additional features like diabetes or acute coronary syndrome or other vascular disease or other very high risk or high risk features, you get extreme risk category. And you need to start with high intensity statin, then add bempedoic acid, ezetimibe as and when required, and if this triple combo fails, you use injectable drugs. So friends, we need to be aggressively controlling our lipids. Of course, lifestyle intervention is always there. You need to stop smoking, you need to control your pressure, you need to control your sugar. But dyslipidemia also is an important factor, which if we control, we can reduce not only stroke events but also other coronary events in the patient with stroke. Thank you. If you like this video, friends, share and subscribe to LAI TV. Thank you.